So good morning friends. Today we will be discussing few important aspects of neonatal resuscitation which are important from your exam point of view. Now by neonatal resuscitation we basically mean the resuscitation of newborns who are transitioning from intrauterine to extrauterine life. And you should know that 10% of newborns may require some assistance at birth to initiate breathing. So, basically, to decide which newborn will require resuscitation and which newborns may continue with routine care, we need to ask three questions. So, for that, you can ask three questions, and these are whether the baby is term gestation, whether the baby is having good tone. This can be assessed if the baby is actively moving his limbs and if the baby is breathing or crying. Now, if the baby is breathing well and if he is crying, then that means he has initiated breathing. So, if the answer is yes to all these three questions, then what the newborn receives is the routine care. Now, routine care is what is given routinely to all the babies. And in this, the infant is dried, the baby is placed skin to skin with the mother so that hypothermia may be prevented, and the baby may be covered with dry linen to maintain a normal temperature. At the same time, you should ensure that the child is observed for his breathing pattern, his activity and the color, and these observations should be ongoing. While if the answer is no to any of these three questions, then the baby should be moved to a radiant warmer to receive one or more of the following four actions in a sequence. Now this is a radiant warmer where the baby may be taken up for the further steps in resuscitation. Now this is a warmer. This is the bassinet where the baby is resuscitated or placed. This is the overhead heater. And this is the control panel, and these are the probes. So one of the probes is the air probe, which is kept here so that the sensor can sense the temperature of the ambient air, while the other probe, the second probe here, is the skin probe, which is placed on the baby's skin. Now the skin probe will assess the temperature of the baby, and accordingly the heater output will be generated. So if the baby's temperature is normal, that means the baby's temperature is more than 36.6 and that is the temperature that is set here, then the heater output would be 0. That means the baby does not need any extra heat to increase his temperature. While if the skin probe senses the baby's temperature to be less than 36.6, that means the baby is hypothermic, then accordingly the heater output will increase. So this is how the radiant warmer works, and it is in this radiant warmer that the resuscitation of the baby will be continued. So the initial steps in stabilization, that is maintaining a warm and normal temperature, positioning, clearing of secretions, that is when they are copious, and so that the airway is clear, there is no obstruction, are carried out in the radiant warmer. The subsequent steps in neonatal resuscitation include ventilation and oxygenation, which may include giving positive pressure ventilation using either a bag and mask or a flow inflating mask or a laryngeal mask airway, or initiating chest compressions if your ventilation or positive pressure ventilation is not working. And finally, if chest compressions are also not working, then we go on to administer medications such as epinephrine, or we give volume expansion if there is evidence of blood loss. So this is the radiant warmer that we have already discussed. So another important point that you need to know is about the golden minute. Now, what is this golden minute? It is the first 60 seconds after birth which are allotted for completing the initial steps, re-evaluating and beginning ventilation if required. So if you see this, if this flowchart, this is the flowchart which you are supposed to follow when neonatal resuscitation is going on. Now, if you know this flowchart, you can answer all the questions that come in your exam. So this is the 1 minute, the golden minute. This is the golden minute which starts from birth, and you ask 3 questions. If the answer is yes, you give the child routine care along with ongoing evaluation. But if the answer is no to any of these questions, then you have to warm the child. So for that, to ensure that the temperature is normal, you have placed the child in the radiant warmer. You have to maintain a normal temperature. You position the airway. You clear secretions. And you dry and stimulate. Most of the kids, in fact, will respond to drying and stimulation and may initiate breathing if they are not breathing. And then soon after this, you have to assess whether the child is apneic or gasping, or if the heart rate is below 100 per minute. Now, there are 2 heart rates that you have to remember in neonatal resuscitation. The first is 100 per minute and the second is 60 per minute. So here we are talking if the heart rate is less than 100 per minute. So if if the answer to this question is yes, the heart rate is below 100 and the child is apneic, he's not initiated breathing, he's gasping, then you initiate positive pressure ventilation along with putting a SpO2 monitor. Now this entire sequence that we have discussed here is to be completed in 1 minute. And this 1 minute is called the golden minute. Many questions are asked on this golden minute in the exam. Now, the decision to progress beyond the initial steps is determined by the simultaneous assessment of 2 vital characteristics. And what are these vital characteristics? They are the respiration and the heart rate. Now, this is what was shown in this flowchart. So, whether the child is apneic or gasping, so that means how the child is breathing, and his heart rate. If less than 100 per minute, then we initiate positive pressure ventilation. Now, once positive pressure ventilation or supplementary oxygen administration has started, assessment should consist of simultaneous evaluation of 3 characteristics. Now, there were 2 characteristics on the basis of which you started positive pressure ventilation. But now there are 3 characteristics which you will monitor. So they are heart rate, respiration and oxygen saturation, which is determined by pulse oximetry. So 3 vital characteristics are what you monitor. But when you are asked in the exam which is the most sensitive indicator or which is the single most important indicator of a successful response to positive pressure ventilation, your answer should be an increase in heart rate. So this is the single most and the most sensitive indicator of a successful response, and that is increase in heart rate. So this is the flowchart that we will discuss later again. So one more point that I want to make here is that if in spite of giving adequate positive pressure ventilation, your heart rates still remain below 100, then you have to look for some corrective steps. And what are these corrective steps? You can remember them by the mnemonic MR SOPA. Now M stands for mask adjustment. So you have to be sure that there is a good seal of the mask on the face. If that is done, then you have to reposition the airway. The best position in which the child can be ventilated is the sniffing position. Then you have to check if you need to suction the baby's mouth, because there may be some secretions which are obstructing the airway and may not be able, which are preventing the child from initiating breathing. So you can suction the mouth and clear the airway. Then if this doesn't work, you can increase the pressure. It is possible that the lungs are pathological. There might be the child may be having congenital pneumonia. There may be a component of hyaline membrane disease. The lungs may be stiff. So increasing the pressure may help the child in improving his heart rate and saturations. And last, Once you have done all these steps, you have taken all these steps and the child is not improving, then you can consider the alternative airway, that is endotracheal intubation. So these are the 6 corrective steps or the MR SOPA. This is the mnemonic by which you can remember. So the anticipation of resuscitation need is to be done prior to the birth. So readiness for neonatal resuscitation requires assessment of perinatal risk. For example, you may know whether the child is born term or preterm, and whether the child's will be meconium, liquor would be meconium stained or not. Though this is not one of the questions to be asked, but it will help you to know whether the child is depressed or not at birth. So basically, there should be a system to assemble the appropriate personnel, and at least one personnel should always attend delivery, a trained personnel for normal deliveries. But if you're anticipating any complications already, then additional personnel may be present who are trained in endotracheal intubation and in administering medications. So before you go ahead attending a delivery, ensure that all the supplies and equipments are functioning. So you can maintain a standardized checklist to ensure that all the instruments and equipments are present and they are in functional condition. So what are the initial steps? The initial steps are basically to maintain the normal temperature of the newborn. This can be done by either placing the child in the radiant warmer or by making skin to skin contact with the mother. Then you should ensure that the position of the baby is in a sniffing position. This is to ensure that the baby's airway is open, and you can clear the secretions if needed with a bulb syringe or a suction catheter. Then you need to dry the infant unless the baby is preterm, and may cover the baby in plastic wrap, and this drying can also stimulate the baby to breathe. Now, to ensure a normal temperature of the newborn in the delivery room, you can use a radiant warmer and you can also use thermal mattresses. Now, how to clear the airway? So when the amniotic fluid is clear, the child's mouth can be suctioned immediately after birth. Since M comes before N, the mouth should be suctioned before the nose. Now, why do we do this? That is because if you do the nose first and if the mouth is still filled with secretions, when you do suctioning, it will provide some amount of stimulation to the baby to breathe. Now, while suctioning the nose, we give stimulation to the baby. All the secretions which are present in the mouth, the baby may aspirate and may cause aspiration pneumonia in the baby. And hence, you should always take care that the mouth is suctioned before the nose. That is, M comes before N, so as to clear the airway. This is when the amniotic fluid is clear. When meconium is present, arrangements should be done so as to ensure that the airway is clear. That is true. But now there are no recommendations for routine intubation and suction, doing intratracheal suctioning to remove the meconium. That is because a child who is born through meconium stained liquor will already be depressed. He may have fetal hypoxia. So these children will be at more risk of developing birth asphyxia and may need assistance for initiating breathing, and hence time should not be wasted in doing tracheal suctioning. And then we need to assess the heart rate. Now, heart rate is used to evaluate the effectiveness of spontaneous respiratory effort and determine the need for subsequent interventions. And like I have mentioned, the newborn's heart rate is the most sensitive indicator of a successful response to each intervention. Now, how will you assess a baby's heart rate? Previously, there were recommendations that this could be done by either palpating the pulsations at the umbilicus or the umbilical artery, or you can auscultate the newborn's heart. This is usually recommended to be done for 6 seconds only because time is crucial for us. So we can calculate the heart rate that we can calculate in 6 seconds, and then we multiply it with 10. and then we will get the heart rate of the child, that is in per minute. So if, for example, you palpate 6 beats in 6 seconds, so the heart rate would become 60. If you palpate or if you auscultate 8 heartbeats in 6 seconds, you get the heart rate as 80. So you do it just for 6 seconds. But over a period of time, it has been seen that palpating the heart rate and by auscultation of the newborn's chest are not too correct in giving you the value of the baby's heart rate. And so there is a recommendation that the 3-lead ECG may be used for the rapid and accurate measurement of the newborn's heart rate. Now, in many settings, the 3-lead ECG may not be present. So, in those settings, the recommendation for palpating at the umbilicus or at auscultating for the newborn's heart rate stay. Now, we come on to assessment of the need for oxygen and administration of oxygen. So for this, we need a pulse oximeter, and the pulse oximeter is to be used whenever you are anticipating resuscitation, whenever you are administering positive pressure ventilation, when there is central cyanosis that persists beyond 5 to 10 minutes of life, and when supplemental oxygen is to be administered. So in term infants, you can initiate resuscitation with air, that is 21% of oxygen, and you can give supplementary oxygen, but this should be titrated to achieve a preductal oxygen saturation. Similarly, in preterms, to avoid injury due to excess of oxygen, whatever oxygen you are giving, it should be titrated to achieve the preductal oxygen saturation. And for this as well, recommendations are given, and these are the targeted preductal SpO2 after birth. So you can connect the oximeter to the baby, and then according to the baby's age or according to the time that has elapsed after birth, you can see what is the targeted preductal SpO2. So at 1 minute, the targeted SpO2 is 60 to 65%, whereas a SpO2 of 85 to 95% is reached only after 10 minutes. So you should not be overzealous in giving oxygen to the baby. So these are the targeted preductal SpO2 after birth, because even giving oxygen can cause free radical injury. It is implicated in the causation of retinopathy of prematurity in preterms, and hence excess of oxygen should be prevented. So now we come on to the positive pressure ventilation. So this is the standard recommended treatment for both preterms and term infants who are apneic, or if their heart rate is less than 100 per minute. Now the devices that can be used for positive pressure ventilation are a flow inflating resuscitation bag, a self-inflating resuscitation bag, and a T-piece resuscitator. So all these three can be used, but the choice depends upon the available resources, the local expertise and preferences. Now you can also use a laryngeal. So these are the devices that are used to give positive pressure ventilation. And again, like I have already mentioned, for giving the positive pressure ventilation, you need an appropriate sized mask. The mask can be either a round mask or an anatomical mask, and the mask should be of appropriate size so that it covers the nose and the chin, and an appropriate seal should be made so that no leakage is there. Then you can give positive pressure ventilation at a rate of 40 to 60 breaths per minute. And then you have to see whether the child is improving or not. You can look for the chest rise. You have the oximeter with you, and another person can check for the heart rate to see whether the heart rate is rising or not. Now, if the heart rate is not rising, then like I have mentioned, you have to take corrective steps. You can follow the mnemonic of MR SOPA to ensure that all these points are taken care of. So once you have seen that MR SOPA has been taken care of, the mask is correct, the seal is correct, the mouth is open, the child's neck is in sniffing position, the airway is in line, you have increased pressure and seen, since still the child is not improving, then you can go to the alternative route for providing positive pressure ventilation, and that is doing a endotracheal intubation or using a laryngeal mask airway. Now, endotracheal intubation is a more sophisticated technique. Many individuals are not trained in it. So for them, if they want to use an alternative route, they can use the laryngeal mask airway, for which you do not need much training. So the laryngeal mask airway covers the laryngeal inlet and can facilitate ventilation in terms and preterm newborns, but over 34 weeks of gestation. And this may be considered as an alternative to tracheal intubation if the face mask ventilation is unsuccessful in achieving effective ventilation and endotracheal intubation is difficult to be carried out. Now, this is the image of a laryngeal mask airway. This is important for you because this can also be asked as an image-based question in your exam. Now, endotracheal intubation is another alternative route which you can follow if your bag and mask ventilation is not functioning, or it is also indicated if you have to perform chest compressions and in special circumstances such as the congenital diaphragmatic hernia, which is one of the absolute contraindications of bag and mask ventilation. So these are the three indications of endotracheal intubation in neonatal resuscitation. Now, once you have intubated the child, how will you know that the child has been successfully intubated? So if the child has been successfully intubated, the chest tube is in chest, you can check it by a constant rise in the heart rate, that is 1, because we have already mentioned that rise in heart rate is the most sensitive indicator of successful each step. Then you can also check the exhaled CO2, which may be detected through, which may help you to confirm that the endotracheal tube is in place. So next we come on to the chest compressions. So in spite of giving adequate positive pressure ventilation using the bag and mask and the endotracheal intubation, if still the newborn is not responding, then you can go ahead with chest compressions. Now when I started my lecture, I told you have to remember two heart rates. So the first heart rate is 100 per minute. That is the time when you initiate positive pressure ventilation. And then the second is the 60 per minute. That is when you initiate chest compressions. So chest compressions are to be initiated if the heart rate is less than 60 per minute despite adequate ventilation, and this is usually delivered in the lower third of the sternum or to a depth of approximately 1/3 of the anterior posterior diameter of the chest. Two techniques have been described, that are compression with two thumb techniques, when the fingers are encircling the chest and supporting the back, that is the two thumb technique, or you can give compressions using the two finger with the second hand supporting the back. So it is important to know that compressions and ventilations have to be coordinated to avoid simultaneous delivery. So the chest should be allowed to re-expand fully during the relaxation, but the rescuer's thumbs should not leave the chest. So basically you have to follow a 3:1 ratio with 90 compressions and 30 breaths to achieve approximately 120 events per minute to maximize ventilation at an achievable rate. Again, this is an important MCQ for you. You are frequently asked in the exam about the number of events that occur or the ratio that is to be followed. So during the time when you are giving the chest compressions, you need to ensure that there is a increase in oxygen concentration that is supplied, and it should be increased to 100% whenever chest compressions are provided. So then we come on to the last step which may be required, and that is giving medications. Now, this is very rarely indicated in the resuscitation of the newborn infant, and bradycardia in the newborn infant is usually the result of inadequate lung inflation or profound hypoxia, and establishing adequate ventilation is the most important step to correct it. But it is indicated if the heart rate remains less than 60 per minute and despite adequate ventilation with 100% oxygen. But medications are preferably administered through the endotracheal So basically, if the medications are indicated if the heart rate is less than 60 per minute despite adequate ventilation with 100% oxygen, which is given through the endotracheal tube and chest compressions. So the medication that is usually used is the epinephrine, which is given in a dose of 0.01 to 0.03 mg per kg of 1:10,000 diluted epinephrine. And if the endotracheal administration is attempted while intravenous access is being administered, then you can give a higher dose of 0.05 to 0.1 mg per kg through the endotracheal tube. Now, volume expansion may also be considered. That is when blood loss is known to occur or is suspected. That is when the baby's skin is pale, has poor perfusion or has weak pulse, and the infant's heart rate has not responded adequately to other resuscitative measures. So now we come on to the last aspect, and that is withholding resuscitation. So basically there are a lot of controversies in this, and every country has its own policy. So, but there is a general consensus that babies born less than 23 to 25 weeks of age, in them resuscitation measures may be withheld, and if the baby is having some life-threatening anomalies such as anencephaly, in them also resuscitation may be withheld. And when can you discontinue your resuscitative efforts? If the baby with Apgar score of 0 after 10 minutes of resuscitation, if the heart rate remains undetectable, it may be reasonable to stop assisted ventilation. However, this decision to continue or discontinue resuscitative efforts must be individualized. But this is just a guideline which can be followed. So with this, I come to an end of my session, a brief session on neonatal resuscitation. This is quite a vast topic, and I have tried to concise it in 30 minutes, including all the important MCQs that are usually asked in the exam. And for many such useful lectures, you can subscribe to the Unacademy Plus subscription program, which will give you access to the top educators from the country who will, along with you, drive you towards your journey to the NEET-PG entrance exam. By subscribing to the Plus subscription, you will get unlimited access to the live sessions, where you will get access to the notes. You will get access to live sessions. You can ask your doubts, clear them right away. You will also get separate doubt clearing sessions where you can ask your doubts. You can also track your progress towards your preparation by attempting the weekly quizzes and the mega quizzes. So do subscribe to the Plus subscription so as to achieve your dream rank in NEET-PG entrance exam. So hope to see you in my next class. Goodbye.